Good afternoon. My name is Bob Welsh. Welcome you on behalf of the Johnson County Task Force on Aging. We've got some very distinguished persons here that I hope you'll welcome, but really the most important people who are here are those of you, okay? So would you give yourself a real round of applause? The first session, which was for providers, I'm glad you're sitting down for this. We had an overflow into the other two rooms, and there were 265 people here, okay? I gained a real appreciation for the people that are special guests. The committee that put this together, besides myself, is Larry Coogee, who's the chair of the Johnson County Task Force on Aging. You don't need to.
Wait a second.
Sean Zerke is the vice chair. And Jane Woolen is clinical supervisor, case management, Johnson County Health and Human Service Case Management, Johnson County Case Management. I think this is an impressive list, okay? The director of the IRA Medicaid enterprise is Mikki Stier, right here. Next to her is Nancy Lind, who is the chief operating officer serving Iowa and Nebraska for UNITEDHEALTHCARE plan of the River Valley, okay? Next to her is Jacqueline Inglis, who is the senior director of field health services in Missouri. She's with the UNITEDHEALTHCARE plan of the River Valley.
No, Iowa. WELLCARE, yeah.
Okay. She's with WELLCARE of Iowa. I got ahead. Mark is not there, okay?
He's
Mark
getting coffee, at least that's what he told me.
Okay. Mark and bailey.forrest are with AMERIGROUP, Iowa. And then next is Mary Pat Sherry, who's the Market Development Director for AmeriHealth, Cadiz, Iowa, and Victor Nagon, Vice President of Public Affairs, and Jim Shelton, who's the Director of Provider Network Management. And the bald-headed gentleman, we spent 2 hours together so I can say that.
That's what you get for coming in late.
At least he described me accurately.
Is Mark Padilla, who's the Director of Business Development for AmeriGroup Iowa. Okay? Let me tell you what our format is going to be. What? What? Oh, Renee Schulte, who's with WELLCARE of Iowa. Welcome, Renee. Let me tell you what our format's going to be. Mikki Stier, who's the director of the IRA Medicaid enterprise, is going to tell you as consumers everything you need to know about managed care, okay? She's going to tell you, why we're doing it, what you can expect, what you need to do, and everything, okay? Then, and they drew cards to see each of the 4 managed care organizations going to tell you about their philosophy, their organization. They're going to give you their sales pitch because, make it clear, you as consumers will be provided an opportunity to make a choice. And you need to make a choice. Enrollment will begin in October. There'll be assistance for you. I'm sure will be, but your last day to make a choice will be December 15th, okay? So you want to be sure you express your hopes, concerns, and where we go. You'll be able to change MCOs if you have good cause, okay? But that ends on March 19th. Now, if you signed in when you came, I hope you did, and I hope you printed legibly, because if you did, I'm going to be sending you emails to keep you up to date on what I know, what they tell me, so you'll have that information, okay? So if you're not sure you signed it, or you printed your name where I can read it, or my wife can read it, check it when you go out, okay? So after these presentations, might have some questions, but then we're going to ask you to express your hopes and your concerns. You know, what issues do you hope these people will address? Okay? And we'll have you come and line up here, and I'll hand you the microphone, okay? So our first speaker, who has one heck of a big job. As I said earlier, we're either going to be good friends or enemies at the end of this session, and I think at the end of the first session, I think, Mikki, we made it okay.
Okay.
So, so Mikki Stier.
Good afternoon. My name is Mikki Stier, the Medicaid Director for the state of Iowa. Again, I want to thank Bob and the committee for putting this on so that we can be out here talking to the community, talking to you all. I'm going to give you a little bit of brief update, but then I'm going to deviate a little bit and get into a little bit more information regarding the members, see if this will help you. So I understand this is a massive transformation, and with change, there's an awful lot of uncertainty. I also know in the last couple of weeks, we have more information, and if you were to ask us in another 2 weeks, we'd even have more information for you. So we're going to try to help get additional information out to you, let you know what we're working on right now at the Iowa Medicaid to work on readiness, to make sure that we are ready with our partners, the 4 MCOs who will be talking to you about their programs and their services. So a couple things that we have been doing at Iowa Medicaid is that we actually have a project management team that's on site working to make sure that the Medicaid department is ready for the transformation, working at the various areas like member enrollment. We will be enhancing our member enrollment services, definitely by staff, but also they are becoming enrollment brokers, and they will be doing conflict-free choice for our members. You will be able to call in, and if you don't want to pick a plan and just leave a voicemail, we will have voice recognition plans available that you can just call and leave a message, and we can enroll you there. We're also ramping up our provider enrollment and provider services on that end. So we've been working with a project management office to do that. As of about a week and a half ago, we engaged a company called Navigant. They are in charge of readiness review. Many of you know that it is a federal requirement that we prove readiness to the Centers for Medicare and Medicaid. They are on the ground. They are working with us, with the providers. There's a whole host of things that these MCOs have to provide to us. Their contracts for provider services, their training, their manuals, their policies and procedures. Network adequacy is going to be a big one. They are certain standards that they have to adhere to. Not only are we going to check it once, we're going to do desk reviews, we're going to go back and check it again, and it's an ongoing process. Through that readiness review, they will build for us an oversight tool, Navigant will, that we will continue to monitor. On a weekly basis right now, we use dashboards to monitor our readiness at IME, and we will be doing the same more frequently with the MCOs to see what their readiness is going to occur. We have, and we will be sending out a whole host of member outreach for you. First of all, we are calling the Managed Care Initiative Iowa Health Link. We're linking your physical, your behavioral, and your long-term services in a link of comprehensive care. Some of you may know about health homes and integrated health homes. That is looking at that whole person orientation. We will continue the concepts of health homes and integrated health homes. The MCOs will follow what our state plan says, what those look like. So those will continue in terms of that comprehensive care for our members. In terms of outreach, we have been and will be doing this week, and the last 2 weeks we were doing provider education. We know our members listen to their providers. We know it's imperative that our providers are trained well to be able to talk to you about these new services and programs. We actually have almost no capacity in those trainings, so we're going to webinars and seminars to help our providers. Outreach to you, members that are concerned. You all should be receiving here shortly a member mailing, and that mailing is just basic information about introducing you to what is managed care. What does that mean for you? What does that mean for your family member? Earlier this summer, we did a group that we pulled in with long-term care services. We know long-term care and those services are very, very important to our members. So we actually have a group of members and their families that gave us feedback. They actually looked at the introductory letter, commented on it, and allowed us to change that letter. So you should be getting that introductory letter. It has some dates on it, similar to what Bob was talking to you about, but that letter should be here shortly, and we're rolling that out for you as well. In addition to that, in October, there will be what's called a tentative assignment. This is member choice. This is very similar to what happened with the Iowa Health and Wellness Plan, is that our members were tentatively chosen into an MCO. In this case, it was a little bit different because in the Iowa Health and Wellness Plan, you were tentatively assigned. Okay, you can then choose to move outside of that MCO if you don't want that MCO. The MCOs will have their provider networks available so you can see if your provider is there, case manager's there, the individuals that are concerned, the MCOs will have those provided for you. The tentative assignment packets are going to be mailed October through November. They're staggered because, as you can imagine, we have 560,000 people to mail packets to. Similar to our introductory mailing, and they will have up until December 1st to choose which of the MCOs. Available to you online will be our member services, and they will be inside those member packets will be information about each one of the MCOs, in addition with how to enroll and how to select that MCO. The third step is to contact. The MCOs will reach out and contact members. They will be giving you provider directories, contact information, what services are available, member protections, rights and responsibilities, grievances, and a whole host of information for you that you can use during the enrollment process. And then the fourth is if you choose, for whatever reason, it's called good cause, similar to the Iowa Health and Wellness Plan, marketplace choice. If you wanted to change between Coventry and at one point Co-Opportunity, you could for good causes, and it's the same way that you can change between the MCOs for good cause as well. And then member services, like I said, is available. We will have a hotline. The member services is also doing public meetings. There will be a schedule, I think there is a schedule available for a whole host of public meetings, similar to this one that we're doing around the state, going out and giving you more information about the providers and their networks. The other thing that the MCOs have to do for us is they have to, as part of their readiness, prove network adequacy. For a primary care physician, it's 30 miles, 30 minutes. For rural and specialists, it's 60 miles, 60 minutes. And for waivers, it's 60 miles and 60 minutes. So these are some of the things that we're working on right now. Again, we do appreciate any communication and feedback from you that can help us make this process and this transition a smooth one. So I thank you.
I keep my notes and I can't find them. Which had number one? Each of the four MCOs will tell you about their organization, their philosophy. Have asked them to share with you why should you choose them. You know, I mean, you've got four choices to make, okay? And this is your opportunity to meet those four MCOs. And so is it Victor? Yes. From AmeriHealth.
Good afternoon. Thank you, Mr. Welsh. The Task Force on Aging, Ms. Stier, and all of you for coming and joining us tonight so we can begin this conversation around the huge transformation that you heard Ms. Stier talk about. AmeriHealth Caritas, we are a family of companies, and we are a mission-driven company. We're out of Philadelphia, Pennsylvania. We were started 30-plus years ago. We were a solution in the Philadelphia community from a provider, a hospital system who was not receiving reimbursement. There were some issues in Pennsylvania, and they needed to come up with a way, and one of the ways was to create managed care so that we could receive dollars and then disperse them appropriately, working with providers, working with our members. And that's how we were born 30-plus years ago. Now we're in 16 states. We have Medicaid. We provide Medicaid services. We do dual demonstrations, which are people that are on Medicaid and they're on Medicare, both at the same time. We provide services for pharmacy for pharmacy management, and we also do services through our Perform Care, which is our behavioral health company. All together, we bring that together to create a real integrated model of care that I'd like to just spend a couple moments talking to you about. Our mission is we help people get care, stay well, and build healthy communities. So we're really excited about being here in Iowa to build healthy communities and support all the great work that's been done here in Iowa and just move it forward. The other thing is our whole focus, we do not have any commercial members. All of our members are focused on the Medicaid and the Medicare products. So we're really excited about that because we hope to bring those 30-plus years of experience here to help you with that. So let's talk about a model of care. You heard Ms. Stier talk about a transformation of integrating the care. Through our model of care, we've got multiple levels of engagement, especially on the member side, so that we can help you and your families become more focused on preventive care and be able to get access to care. Because I think when we talk about access, that's the biggest thing. So we do everything from case management, care coordination, work with your providers, but we also have something called the Community Outreach Solutions Team. And it's pretty interesting because that came from the need to engage our members where they are, where we actually have folks who will help find and identify members, especially those really in need, so we can get them re-engaged in healthcare. Because again, we find that when we meet you where you are, we can then come up with solutions that are beyond healthcare that can begin addressing some of the issues you have. So with AmeriHealth Caritas, we're really excited about being able to provide services to you. We're looking forward to be an option for you, and we hope that you give us an opportunity to provide services to you. Thank you.
Go ahead.
Introduce yourself.
Hi, I'm Nancy Lind. I'm with UNITEDHEALTHCARE, and I'm very pleased to be here today with all of the other MCOs. UNITEDHEALTHCARE is a company that has been in Iowa for probably about 30 years. Fortunately, I'm not sure. I've been with the company 28. So I've been around for quite a while. I used to be a nurse up at Covenant Medical Center in Waterloo, Iowa. And so I really do understand Iowa. And Iowa is very important to UNITEDHEALTHCARE, and that's why we've been in this business in Iowa for 30 years. We have multiple products within the state. So we do have commercial insurance that employers purchase and provide to their employees. We have a Medicare supplement and a Medicare Advantage product. And we also serve the military and veterans through Tri-West. For my division of the company, it's called UNITEDHEALTHCARE Community Plan, and we're solely focused on Medicaid products. And so in the state of Iowa, we've been serving the Hawkeye population here since 2000, and I've been part of that since 2004. So what do we do? That's really a question that a lot of you want to know, and I'm hoping that I can help answer we really look at the patient-centered model of care. And what does that mean? It means that we look at you as the individual. What are your individual needs, and how can we help you connect to the right providers and the right services during your care needs? That might be preventative services, and it might be really complex care. It might be moving from the hospital and trying to get out of the hospital back to your community, or sometimes transitioning to a nursing home. So we have members throughout the United States. We serve currently 24 states, and we provide those different types of services to all of our members, really trying to connect with them at the right time in their life. So it might be a mom and baby, helping them understand the importance of prenatal care and getting well baby checks. It might be with our elderly population, really making sure that you're able to stay at home as long as you can. And what services can we provide and bring to you so that we can provide those services in your home, or really make sure that it's safe too. Sometimes a safe environment and a quality environment is really our focus. So one of the things that we try to do is to provide those services from our clinical team, as well as our member service and provider services team. So within UnitedHealthCare, you'll have a member service representative that will help you maneuver through the system. You can call us and help, we can help you with any claims. We can connect you to our clinical team, as well as we can help work with your providers. Our provider services teams work with our providers to make sure that they have the services they need, the information that they need to provide the care whenever you're needing services from your provider. And our clinical team. We'll have a team throughout Iowa serving all the counties in Iowa available to serve you at those different times of your life when you need some assistance, and really try to help coordinate that. We believe truly a care coordination plan is around bringing the provider, the member's caregiver, and whoever is participating in that service, if that be a family member or a caregiver, bringing them in to really make sure we understand the needs of our patients, and developing a plan around that patient so that they're safe and they have quality of health care. So we look forward to serving Iowans as we've been serving Iowans, and continue to expand that into the Medicaid population. And we look forward to working with all of our members and providers across Iowa as we do that, as well as the department and other organizations that support the members today. Thank you.
Good afternoon, everyone. My name is Mark Padilla. I'm with AMERIGROUP, another one of the contractors that has won the contract. I want to let you know that we actually had a meeting before this for the providers, and we drew cards to see who would go first, second, third, and fourth. And I was fourth the last time, and I'm third this time, so I'm moving up. So real excited for that. Thank you for having us. Thanks to my colleagues, thanks to the state, thanks to Bob. I haven't been here 28 years, but I have been here long enough where I am paying taxes in Iowa. So, and that's really key to what I want to tell you. So, AMERIGROUP is a national Medicaid managed care company. This is all we do. We are in 19 states across the country, serving all types of Medicaid members, long-term care members, elderly, people with disabilities, kids, moms, some with physical health and behavioral health, some with physical health only, anything you can think about it. In one of those 19 states, we're probably doing it. And I mention that because I think that's important. I think it's important for you, the members, who are really central to this whole thing we're doing. I think it's really important for the members to understand that we think we have the expertise and the experience and the resources to make this happen, and to make this happen in a way that works for you. We are currently putting together an office in West Des Moines, even though we may be we are looking at some other locations as well, maybe some satellite offices. I want to tell you that the provider session earlier this afternoon, I hope your ears were ringing, because we were talking about you guys. We were talking about members. And I went into this thing earlier this afternoon about, as a Medicaid managed care company, we have 3 sets of customers. And this room is filled with the number one customer we have, and that's the members that we are charged with and get paid for by the state to manage their health care. If we do right by you guys, then a lot of the other things take care of themselves for us. Our job is to coordinate your care, to make sure you're getting the right care at the right time, that it may be a little different. You may have been getting something in the past that we know from experience or from something in another state, where a little more of this will be better than some of that. We're not going to come in and make wholesale changes. We want to talk to you. We want to talk to your providers. We want to talk to, just like my colleague said, the patient-centered care is all about the patient in the middle, with family members and caregivers and doctors all around that person. We want to make sure that we make the right decisions for your health care. So how do we do that? So we have been out here in Iowa for months. We are contracting with all providers that are willing to talk to us. And the room, I think this morning we had 280 people, 260 people here earlier this afternoon. So we are talking with providers. We are working with the state. We know the program implementation date is just around the corner. And we are working really hard, again, pulling in resources to make sure that we implement this appropriately. So we're excited to be here. I want to make sure that you guys leave here, if there's something that you leave here with, is always remember that you are our number one customer. We have to take care of you. We have to take care of it appropriately. We have to work to manage your health care appropriately. And that's our number one focus. Like I said, everything else kind of falls in line if we do that appropriately. Thank you again for having us here, and be happy to answer questions when we get done.
I was number 3 before, but now I'm 4, so I hope that doesn't mean anything. What I want to add to the conversations, while WellCare of Iowa, I reiterate all of the comments that my colleagues have made. One of the things that I will add to that conversation is that we too have been in the market since 2014, meeting with provider groups, meeting with members, meeting with ancillary services, all of the agencies that are there to help support you as members. I mean, we felt it was important to have boots on the ground to really understand the marketplace and what you really need from a managed care company. And to that end, we use that information on how we can tailor our programs to meet your individual specific needs. One of the things, WellCare is also a national company. We're headquartered in Tampa, Florida. But I think the most important thing to remember is that while we are national in scope, we are certainly local in focus. We're going to be having 8 different offices across the state to help us manage our membership and to provide you with the services that you need. The other thing that we do and that we have spent considerable resources on is to really develop our community advocacy model. And by that I mean we have a network of social service agencies that are at our fingertips to outreach to engage, to help you meet all of your specific needs. Each one of you is an individual, and I think it would be wrong to assume that it's a one-size-fits-all. Your needs may be different than somebody else's, and we take that into consideration. Our care management programs, our outreach programs, our collaboration with providers takes into consideration all your specific individual needs that you may have. We're very grassroots. We look at the communities in which we serve. How can we tweak our programs to meet those needs? What do we have to do? While our programs are founded on a strong platform, I think it would be interesting to all of you to know that they are flexible and nimble enough to take care of all of your unique differences. We have business in 9 different states, and like some of my colleagues here, we only focus on government programs. So our experience in implementing and managing markets across the country, and large markets, small markets, we treat them all of the same, and we provide all of the resources that are necessary locally with support from our corporate office on how best to manage your care. Anybody have any questions? I guess we'll take those after. Thank you.
I'm going to ask you 3 questions rather than Larry and Jane asking you questions. I'm going to ask, and Mark, I'm going to begin with you, and then Victor and Paul. Mentioned preventative care. Can you give me some examples of what you've done in relation to preventive care in other states? Let me make sure. I'm not sure I've said this. They are in contract negotiations, okay? So they cannot tell you what they're going to do right now, okay? They can tell you what they have done in other places, which will give you an idea as to what they're probably going to do in Iowa, okay? So, you know, in terms of preventive care, what kind of things have you done? And then the others will either say, hey, we do that too, or they'll add to it.
Thanks, Bob. So as a managed care organization, again, charged by the state to manage healthcare, one of the things that we want to do is make sure that people, members, are as healthy as possible. And if they're not healthy, we want to work really hard to get them healthy. And I know that's kind of a blanket statement, but that kind of talks about our whole approach to preventive care. So when we talk about preventive care, we want to make sure that it's well child visits, that it's immunizations, that people are getting the care that they need at the appropriate time. We want to avoid that emergency room. We want to avoid that long-term hospital stay or that long-term care stay. So how do we do that? We do that by trying to get as much information out there and then kind of drilling down to that individual member to make sure that they are getting the preventative care that they need. It's not about denying care. It's about providing as much appropriate care as possible to avoid that long-term, expensive episode of care. And to me, and to us as a company, and I'm sure my colleagues are going to say the same thing, it all comes down to preventative care, to finding those people out there that need the care and getting it to them at an appropriate time.
Victor?
Great job, Mark. That is pretty much what we attempt to do, all of us are attempting to do, is to work specifically with our members and our providers on trying to address those things that could be avoided, those things that could be avoidable. Because when things happen like emergencies and things that you need care, you're going to have access to that care. But let me give you a couple of examples. So for a woman who is of child getting ready to have a baby, we have a program that we run in other states called Bright Start, where it allows support for prenatal services to make sure that they get whatever services they need, take away any barriers from them getting their prenatal care prior to having the baby. We have programs like Healthy Hoops, which is where we use basketball to educate children on the importance of asthma and making sure that you are utilizing the appropriate medications from an inhaler perspective. So it's those type of health prevention programs that we'll be working with the community to make sure that we educate ourselves. All of us, our lives are very, very busy. We're all very, very busy just trying to keep things moving, and at times we forget to go get our mammogram. We forget to go get our cervical cancer screening. We forget to do our annual visit. I had my doctor, send me a letter the other day, said, "Hey, Victor, where are you?" I got to go get my annual physical. So all those are part of preventive services that we hope to bring to the table to get you out so that this way you can continue to take care of you and your family in a more preventable way.
Jacqueline, you want to go next?
Sure, I do echo those things, but a couple things that I'll add to that. We work really hard to remove any barriers to care and services that you may have. We do this in our other markets in a variety of ways, by sending reminders, by making phone calls to remind you of an appointment. We also offer in our other markets scheduling appointment assistance. If you need help finding a time that fits in your schedule for your appointment, we work with our providers and our members to do that. Again, it's written reminders that we've used in our other markets. We've also had, like I said, the telephonic type reminders. We work with our customer service agency to also, if you were to happen to call in for a different reason in our other markets, the customer service folks can remind you, "Hey, we know this is missing. Do you need us to help you schedule an appointment?" So those are some of the other ways that we work in our other markets today to promote preventive care. It's adults, it's children, men and women, all across the board. It's important, even when somebody has a chronic illness, to still work on those preventative health maintenance type activities that everybody either sometimes forgets, doesn't want to go for, can't get there with. So we offer that in our other markets as well.
And I would echo almost everything they said. Preventive care is one of the critical things for all of our members to make sure that they stay healthy. And it's not always the best time to go get a mammography or have a colonoscopy, but it really is truly screening to make sure we catch diseases early and can treat them early so that there's not a bad outcome from that. So preventative care, we do many of the same things that my colleagues talked about. We try to remind members to make sure that they go in. And we do programs, we build programs around different things. So in one of our other states, or several of our other states, we have Dr. Healthy Hound, and Dr. Healthy Hound is our mascot. And he comes out and goes to school assemblies and helps teach children about making sure that they're staying healthy, and do exercises with them, and make sure he brings home immunization cards, so they're making sure they're getting their immunization cards. So that's just one of the things that we do, but we try to build programs around the different preventive services to really encourage all of our members to go in and get those services from their providers.
Can I add something, Bob?
Sure.
So I just want to acknowledge that, navigating the healthcare system is hard. It is. I try to do it on my own, and I've been doing this for 25 years, and I go, I can't. Now, with health plans in place, regardless of the one that you sign up with, you will have somebody to help you navigate through the healthcare system. And it's a simple phone call away. If you want us to come see you in person to help you navigate through this healthcare system, we'll come see you in person. So let's just all acknowledge that navigating healthcare in the year 2015 is extremely difficult. And the more health issues you have, the harder it gets. We're here to help you navigate through that system and get you to that right care at the right time. Thanks, Bob.
Yeah, you sure can.
We're all going on and on about this topic, but I just wanted to add, someone earlier mentioned that healthcare is local. And one of the things that we do when we're looking at opportunities to engage people earlier in their health care is to identify certain disease states or certain issues in certain communities that might be based on the significant data that we receive and that we use to build, like maybe, you know, heart disease is prevalent in one area, diabetes in another area. We can easily tailor programs to meet the community's needs. We've done a number of supermarket tours in other markets where we'll take people on a tour of the supermarket and show them how they can make healthy meals and still, you know, maintain the flavor and things that we love to eat and make it a little bit healthier. In other areas, we had a competition, Lose to Win, was kind of like the Biggest Loser type of competition. We did it with our area local YMCAs. There were 7 or 8 branches that participated, and we actually had a contest, and people could win prizes. And I think the gentleman that won lost 90 pounds or something. It was great. And so what I want you to know is that when we look at different areas, we're not going to just, you know, again, cookie cutter, throw these programs out. We're going to base it on what those needs of your community are, and that's how we'll build those programs. We collaborate with many other health organizations, you know, for smoking cessation programs, you know, so we'll be looking to partner, again, with what things are actually, you know, going on in your community. In fact, the Governor's Healthiest State Initiative was one of the areas where we'll be looking to partner, as well as the other MCOs. And so, again, looking what's in place and looking for opportunities where we can kind of build out based on your needs. That's where we'll go.
Okay, you hit on my next question, and I got down that Victor's going to answer it first. If I read right, you all can offer consumers incentives. And in terms of your past experience in other states, what kind of incentives have you offered consumers?
We're first, right? So incentives are built really to try to help us focus on that preventive care side, because it's not easy. Again, every day, you know, health becomes really important when you're ill. And then when you think everything's okay, again, I have to go for my annual visit because everything's been going okay. So we've done incentives that go from supporting folks in getting mammograms, gift cards, transportation to provider offices, a multitude of things that allow the quality of life to be improved. And for us, they're quality indicators that we'll be working with the state on in terms of being able to meet quality preventive screenings for all of our members. So we've done incentives for cervical cancer, moms-to-be, again, pregnant, expectant moms. There are just general group of incentives that allow folks to get motivated about preventive health. Because again, every day you wake up, you go to work, you go to visit your doctor, you do what you have to do, and every once in a while we forget some things, so we try to build those models so that we can remind you to make sure that you stay on top of yourself. You're really good at taking care of others, but staying on top of yourself sometimes is a little difficult.
Jacqueline, you want to comment?
Sure. In our other markets, we've done similar things, but I would also add that in one of our other markets, we've had as an incentive to promote healthy lifestyles is, you know, memberships to Weight Watchers or Curves, childhood diabetic camps. So a child with diabetics can learn how to better take care of themselves. The same thing is true for asthma education camps. And then there's other incentives that I will say really look towards promoting health and wellness and healthy living, such as, you know, Boys and Girls Clubs and Girl Scouts and Boy Scouts, those types of, we've used those strategies in other markets to promote health and to offer alternatives for our members to participate actively in their own management of their own healthcare concerns.
Nancy?
Very much the same. You'll hear a lot of us, you know, kind of say the same things. So in other states, we have worked with Boys and Girls Club, Girl Scouts, Boy Scouts. In Iowa, we've always worked with Herky Hollow, which is the diabetic camp over in Boone, Iowa. And so we have done many of those different types of things to really incent members to make sure that they're getting the cares that they need. So adults getting their flu shots, making sure they're getting their annual physicals, their mammographies. And so we put incentives around those. Some of them have some innovation around them where we use a computer or a smartphone, and others are really trying to promote education, making sure that the members are needing, those services, so really kind of trying to encourage them to do that. We've done different things like gift cards. We've done different promotions where we have an incentive pool to try to get everybody working together toward the same goal, such as a weight loss. So I think you'll hear a lot of those, so the same from all of us. What's really important though is how do we get you to the right care and the right services so that you can stay healthy. And what we try to do is understand our membership so that we can create those incentives around what our members need at that time.
Mark, you want to add anything?
Yeah, no, same thing. Pregnant woman gets all of her prenatal care. We offer free car seats for the baby. For kids, we want to give bike helmets. We do the same thing with Boys and Girls Club memberships. We have a program called AMERITIPS where if a person is a diabetic, we're going to provide them with information about how to cook healthy and everything like that. So the other thing that we do is that we try to get out in the community as much as possible. We will go to health fairs and we will sponsor community events. If there's a organization in the community that has anything to do with the child and that child's well-being, we want to sponsor that organization and help them with stuff. And this comes down to school supplies. We do a lot of sponsoring of food banks. So again, this is a good question because it ties right into the preventive care. And if there's anything we can do, excuse me, to incentivize a member to get that preventive care, if it makes sense, we want to do it.
Thank you. I was going to ask you another series of questions, but I think this is a good time to, I'm going to ask Mikki a series of questions, which she doesn't know, and will, as I said in the first session, haven't met her, and we're either going to be good friends or not at the end of the day. But before Mikki do that, I want you as consumers to know that your legislators are concerned about this whole process. And in this area, we have 3 senators, and they all are here today, okay? The newest senators, Kevin Kenney. Kevin, stand up so they see you. And Bob Dvorsky. And not that he's the best, but my senator is Joe Balcom. And we have 3 of the representatives here. Again, I'll identify which one is mine, but I have had good experience with all of them. Vicki Lensing. Vicki. And Sally Stutzman. Sally and I go back a long, long time together. And my representative, Mary Masher. Mikki, you want to come up and stand here, and we'll see how we get along.
That's fine.
Let me tell you, please understand if Mikki says, hey, we're in negotiations, can't answer that question, okay? Okay. The Des Moines Register on Sunday had an article about fraud. Mm-hmm. And they pointed out some of these companies had to pay this fine, this company this fine.
Can you speak in the microphone?
I'm sorry.
It's really hard to hear.
I'm sorry, thank you.
Please, thank you.
I'll get it this way. The Des Moines Register had an article about fraud and pointed out that all of these companies had to pay penalties. What is the state of Iowa doing to assure that they're not going to be guilty of any fraud?
There's a couple things that the Department of Human Services does and Iowa Medicaid does right now. We have a program integrity unit, and that unit is here now in the ground constantly. Most of probably Iowa doesn't realize that there is one there, but it does look at providers. It looks at our payers, looks at making sure the billing is done correctly, making sure that things are filed timely. In addition to that unit, we are also then building oversight with the readiness review team that we've brought on board called Navigant. They will look at things, again, like claims, and we will build a dashboard, engage our program integrity unit, and do investigation in terms of timely filings, the appropriate services to the right people, were they billed correctly. There's a whole host of things that we look at in our program integrity unit to ensure that we have the right oversight, to ensure that we avoid fraud.
Each of these companies have said some of the things they're going to do, and these people have heard them. How are you going to get that information out to all the providers? I mean, all the consumers?
Right now, there's several ways that we do that. We have the Medical Advisory Committee, or MAC. I can never remember the last C is, so one of these days I'll figure that out. But that committee is made up of a whole lot of associations, member associations, community associations. They will communicate different services to them. We do member mailings and enrollment. We have everything on our website that is available that we can communicate to you as well. And then we'll also work with the providers and the MCOs in collaboration to do additional communication via web, newsletters, and et cetera, to get the information out for you guys.
Now, all of the present consumers that are eligible, are they automatically eligible now, or is there something they need to do?
Again, Iowa Medicaid will maintain eligibility. We will determine the eligibility just like we do today. So as your eligibility, you have to renew, will come up. We will keep you informed about that. So there isn't anything that you will do other than the fact that you will be getting an enrollment packet the first part of October, somewhere in there, that we will walk you through what you need to do in your next steps in that packet with a bunch of information, including information from each one of the MCOs in that packet.
Can you tell them specifically, I mean, some examples of what things they should do or look out for?
I think, hang on, let me see if I can help you with this. So in that packet, if you do nothing, it's a tentative assignment. And you will be introduced to an MCO that through an algorithm similar to MetaPass, most of you in this room are familiar with MetaPass and how that algorithm works. It'll be a very similar algorithm that we will use to tentatively assign you to one of the MCOs. In that packet will be information about all 4 of those MCOs. If you have questions, you can call Member Services at Iowa Medicaid, and they are conflict-free choice counseling will be available, which is a new service of ours. And that is that all of our counselors are going to go through training to learn about the MCOs and give back feedback and questions. If you have questions, you can call them. And then if you choose to stay with your MCO, you don't have to do anything. If you want to change, you can call Member Services, talk to an individual, or go online on the voice recognition system and say, I want to stay with this MCO, or no, I want to change. In addition, if you have good cause reasons that you would like to change, similar to what you do today, it's the same processes that we use for Member Services.
Tell them what the good cause would be. Again, see my notes here. You have until December 15th. They're going to assign you. You can, I asked the question earlier, what if all of us in Johnson County selected one of these 4? You can do that, okay?
So things like good cause are, they may include things like the provider is no longer being enrolled with that MCO. A provider decided to change the MCO, because keep in mind the providers can change. That's one. Or if there's a type of service that you need that isn't being offered by one of the MCOs but in another MCO, you can change because that MCO doesn't offer the type of services that you need. And that's because they didn't contract for those services. Okay?
I think that's fine. So this section is now all yours, okay? Would like for you to come up, form a line if you want to. And what we'd like for you to do is to express your hope, your concern, okay? Your hopes or concern. If you have a question, you'll need to phrase it in terms of not what are you going to do, but what have you done in past, okay? And we'll check and see whether or not they can answer them or not, okay? So introduce yourself, express your hope, your concern, and what I've gathered is these people want to hear from you, okay? They want to take into account what you feel, okay?
Thanks, Bob. Mary Masher, State Rep, and I want to thank you all for coming today. We do appreciate you being here and taking your time to address the audience and answer questions. That's really important. First of all, I want to thank you for the emphasis on prevention, because I think that is the key, and that's one of the things that we haven't seen delivered and carried through in a lot of our managed care systems. And so I'm hoping that that will come true and that we really will be able to offer the gym memberships and the opportunities for people so that they can keep out of the healthcare system and obviously keep a good, long, healthy life. When people hear managed care, what they hear is managed costs and less care. And that's what I want to find out from each of you is tell us which states you've been actually able to show a savings and increase the quality of care for the people who need it the most.
I think if I've got this right, read my writing. Jacqueline, I guess you get that question first.
Get my notes out. WellCare in some of our other larger markets, WellCare, New York, for example, and in even Hawaii, we've been able to implement programs that are very member-centric and field-based that allow us the opportunity to meet our members where they are and provide those types of services, counseling, direction at that level. And in our New York market, there are very stringent outcomes measurements that are produced by the state of New York that we have been able to improve over time. What the other thing I would like to point out that with this being a brand new market, what you'll see is the improvement over time. I mean, as these programs are implemented and become mature, then we should see that savings go over. But those are two markets that we've worked with. New York happens to be a long-term care market that we've been able to really address the needs of that population by a very member-focused, feet-on-the-street, field-based type program. And in Hawaii, it is similar with the long-term care, but we've also seen improvements in prenatal births, you know, holding or looking at babies that stay longer before they're born, those types of things, and working with our provider groups to incentivize them as well to provide the right type of care in the right setting. So those are two of our markets where we've been able to show improved outcome for preventative type programs.
Nancy, are you prepared to answer that?
Sure. So for UnitedHealthCare, we really do focus on preventive services because we know if members stay healthy, the cost of their care stays less because we've avoided higher, sorry, I know I'm kind of soft-spoken. Can everyone hear me now? So what we really focus on is making sure we focus on prevention and outcomes because we know that follows along with how to really handle cost. Because if we can get people in for early services, making sure that they have those services early, get diagnosed faster, there's a better outcome, and then that means they're not having really long hospital stays or really catastrophic services later. So one of the things that we really focus on in all of our markets is preventive care. And we've been able to do that in several of our markets where we've been able to really change the health outcomes of our membership, and we would continue to really focus on those health outcomes in all of our states.
Mark, you want to?
We do a lot of the same things, but I'm going to give you an example of a long-term care population that we had. So in most healthcare systems, is that me? I can talk loud. So in most healthcare systems, the trend line for cost goes like this, right? I mean, when have you heard of a healthcare system costs of the trend line going down? So to get to the representative's point, what we try to do is manage the care as appropriately as possible, get the preventative care, and then for those certain populations, I'm going to use long-term care as an example, and I used it this afternoon. The state that we were working in, they commissioned a separate independent organization to do a study of what we were doing in a state. And there was a couple things. There was people that were in nursing facilities that wanted to come out of the nursing facility and get back into the community. When a person's in a nursing facility, the quality of life is super low and the costs are super high. The minute we get them back into the community, if we do it right, those things reverse themselves. The quality of life goes really high and the costs go low. The other thing that this independent organization was able to do was quantify, because of the services that we were able to deliver to people that were at imminent risk of going into the nursing facility in the first place, we were able to keep them from going into the nursing facility. So what happens, the projected costs for the state for that program kind of went like this, but when we started and the maturity of the program started to evolve, the cost started going like this. So the rate of climb was not so high, and that's what we talk about as far as trying to bend the cost curve. So I talk about this all the time, but I want to tell you that I focus on this question about the cost. But really, it comes to quality of life. We're not going to do anything. We're not going to take somebody out of the nursing facility if they end up going right back in. Doesn't make any sense. We're not going to take somebody out of the nursing facility if they want to stay there, right? There's a place for nursing facilities. My dear grandfather lived to be 99, and at the end, he had to stay in the nursing facility. So we're constantly balancing cost against what we can do, again, to deliver that right health care at the right time. But we do have some examples, and I'm going to send Bob that report. The Hilltop Institute did that, and I'll send you that report. It has some great information in there.
Victor?
So, Representative Masher, when you talk about managed cost, it's very interesting. I'd like to talk a little bit about network equity and access. Then I'd like my partner Jim over here to talk a little bit about utilization, because we don't think of it from a preventive perspective. So in Pennsylvania, for example, we've been able to create some real network equity. Organizations like Children's Hospital of Philadelphia, University of Pennsylvania, who are providing top-notch services to the Medicaid population to make sure that they can get access to the appropriate care and to that quality of care. In Pennsylvania, we've worked directly with the state of Pennsylvania on a multitude of programs and risk corridors in order to make sure that there's access to populations that need, because if you can see a doctor, if you can get access to that health care today and not wait 4 months for an appointment or not wait 7 months until a doctor finally gets hired, it allows you an opportunity to kind of catch that ailment, that issue, and then it reduces the cost in the long run. It's that investment on the front end in terms of getting access to care. What I'd like Jim Shelton to talk a little bit about now is utilization and how we don't look at it like this. We kind of look at reducing cost versus investment in care.
Yeah, and one of the misconceptions of managed care is that there is a denial of services. Nothing could actually be further from the truth. What we see when we go into a state is an actual increase in utilization, because what we're doing is we're engaging patient populations, we're engaging providers through incentives. We're making certain that that member is getting appropriate care at the appropriate place. And we feel that the medical home is obviously one of the beginning points for that appropriate place. One of the things that we did in our enterprise last year alone throughout our company and throughout the country was we reduced ER utilization, inappropriate ER utilization, by over 10%. And we did that through direct contact with members. We would outreach to our diabetics. If they were having trouble understanding how to modulate their sugar levels, then we made certain they received education, how to read that, how to make certain that they're eating properly, make certain that they're doing regular testing. And that's just one of the instances where by a managed care company, and all of us are doing this, but by engaging the member in their homes with education, correct clinical practices, we actually see better utilization, higher utilization, but in the appropriate space.
Hi, I'm Dawn Francis. I'm the Executive Director of the Iowa Statewide Independent Living Council. I have a whole lot of hopes and a whole lot of concerns, but I'm going to try to just narrow it down to just a few that I want to point out. And one of the things, the themes I heard earlier today at the providers meeting, and Mark, I think you're the first one that said it, is that I want all providers to contract with all MCOs. And I heard somebody else echo that too, and I certainly hope, because I will let you know that there's a story going around that there's one MCO that is trying to enter into exclusive contracts with providers. Now hopefully that's not true, but I'm just saying that's out there. And, that would be really detrimental, because, one of the things I'm really concerned about and that I've heard from other people is I have a disability and I have multiple doctors and multiple specialists. I choose Mark's, AMERIGROUP, but I look at who your providers are and I see, well, 2 of my specialists aren't in there. So what happens to that person if they choose an MCO and all their doctors and specialists aren't in there? Can an exception be made? The other 2 big things that have been an ongoing issue with Iowa's long-term care system, even before we did this Medicaid modernization, is the lack of adequate in-home providers. Obviously, in the larger areas like Cedar Rapids, Des Moines, we have more, there's more access, but in our rural areas, it's a huge issue. So, I want to know what you guys are going to do to build that provider network. Also, transportation. If you live in a rural area, your provider might be 2 hours away. It doesn't matter whether they're your regular provider or a specialist. These caps on 30 miles for a regular provider and 60 miles for a specialist are not going to work. And then lastly, we do have a lot of really good resources that can help the MCOs. Centers for Independent Living, number 1, are mandated under the federal guidelines to transition people out of institutions back into the community, and to also prevent people with disabilities, and including the aging and including our veterans. They're also charged with preventing them from going into institutions. The problem is it's an unfunded mandate for them. So if the MCOs contract and provide the funds to do that, you're going to help them achieve their mission, you're going to help people, and it's going to be much less costly to keep people out of institutions. The same thing with the AAAs. They are also a great resource for the MCOs to contract with for those kinds of services, specifically for the elderly in the centers for people with disabilities. And it's a whole lot of different things that they can do, such as assistive technology, ramps, personal, trying to develop a personal care attendant program where centers and AAAs start trying to recruit and train personal care attendants that people can choose then who their personal care attendant is. They'll have a list to interview from. So those are just some of my hopes.
Which one of you want to respond in terms of what you've done in other places in relation to the concerns she mentioned about, like, transportation, caregivers? Any examples?
I'll take the transportation one.
Go ahead, Mark.
So, is this better? It's my friend here making sure I can be heard here. So I come from the state of New Mexico, and New Mexico is the 5th largest state geographically in the country. And that means we have urban areas, we have rural areas, we have frontier areas. Most of our counties are designated as frontier. And transportation is an issue, and we get creative on that. The one that I like to share is we were doing long-term care, and we had a senior center. It was actually on a Native American pueblo, which is like a mini tribe. And they were about 60 miles from Albuquerque. So in order to get somebody to the Indian hospital, which was about 12 miles away from that pueblo, in some cases, we had to send a cab from Albuquerque to that pueblo, 60 miles away, take them 12 miles or 18 miles, whatever it was, to the Indian hospital, bring them back, and then come back to Albuquerque. Well, that's 120 miles where that cab is empty. We not efficient, right? Costly. So we started working with that senior center, and we realized that that senior center had 2 vans that was sitting there empty most of the time. We worked with that senior center to get them to be a contracted transportation provider in our network. All they had to do was call. We would call the senior center and say, go pick up this person at this time, take them to the Indian hospital and bring them back. So we saved that 120 miles that we were paying that cab company to not have anybody in the car. It's stuff like that where if there's existing challenges, especially in some of the rural areas, we're going to get creative, and we're going to stay within the rules and regulations, but we want to get creative to find some innovative solutions to those long-standing challenges that Iowans face.
Victor, you want to address it?
Yeah, I just think Mark gave a great example of a managed care company working with a community and the resources. And Ms. Francis, I would just recommend that you continue to provide us those type of resources that are in the rural areas, because those problems exist right now. They're not just going to go away unless we really come up with those creative solutions. So I would recommend that you continue to talk to us and continue to push those type of creative ideas, so then we can work with our state and make sure that we can get those things approved and move forward.
Jacqueline, you want to comment?
I'll take, we've done similar things for transportation, but I'll take the exception piece of that question. And again, I can't stress enough the individual nature of taking care of members. And in other markets of WellCare, we were able to do what we would call a single case agreement with a provider that's not in our network to continue to take care of your needs. Ideally, we would like everybody to be in network, but that isn't always the real life example. So in the market that I'm currently in Missouri, we do a lot of single case agreements for our members to be taken care of with the providers that they're most comfortable with.
Nancy?
Yep. So I'll take a little bit about the network piece. Truly our plan is to contract with any provider that wants to contract with us. We're out in the field wanting to work with all of the providers, if that's medical physicians to behavioral physicians, in-home workers. We really want to have all of those contracted. I think all of our MCOs around the table here are saying the same thing. We do want all of the providers, because we know that it's difficult if you have your primary care physician in network and you choose the health plan because of that, and then you can't see your specialist. So it's truly our hope that all the providers across Iowa will work with us. We're very willing to work with all the providers because we want the member to see any of the providers that they need to.
Thank you.
Hi, thank you. My name is Bill Stump, and I am from Dubuque. I'm a parent. I have an adult son with an intellectual disability. I do have to say that I'm glad that we're addressing preventive care, and I appreciate that. So my comment is more, but I'm also disappointed that that's all we're talking about. Some folks with, thank you. Some folks with intellectual and physical disabilities are just working every day to maintain. They aren't going to go in an upward status. We'd all like to see that. I'm also a nurse by profession. But my question really relates and kind of adds on to the last speaker. We've talked about the medical model. I also understand, and we have a great case management system in Iowa, I think. We have many individuals that have had the same case manager for all their life, and they may be well into their 20s. And my understanding is this may leave, and the MCOs will take over case management. Well, it's not all about medicine. Please speak to your expertise in the areas of such as habilitative services, employment services, and community living for people with disabilities. Thank you.
Victor, you want to start saying any response to that whole?
Well, I think earlier with the providers we were talking about, Bill, we were talking with a lot of the providers that were here earlier that are actually case managers in some of the Department of Healths. And we're continuing to negotiate and work with them to figure out what's the best model in terms of how we can build that out. For AmeriHealth Caritas, we have multiple different models that we can use with our model of care where we do extend out our care coordination out into the community. And I think I can speak for our colleagues. All of us are looking to how we can benefit from those care coordinators and those relationships especially that are out there providing those types of services. So we are continuing to negotiate, and we are looking to try to get that accomplished. So just bear with us, keep working with us, and we're going to keep working with them. By the way, please make sure that those great case managers, those great organizations are reaching out to us also so that we can identify them and work with them. Okay?
Jacqueline?
Sure. I briefly touched on our community advocacy network that we have in WELLCARE. And that program is really about cataloging and understanding and working with all of the community resources that are available, actually down to the zip code level. So as we work to coordinate care with whether it's your case manager, our own case manager, the provider, that listing is able to talk about what's available from an employment perspective, what's available, resources that person may need to really address just the daily activities of living. What do you need to help yourself survive when you have a disability that is away from the medical component and the preventative care component? It's really, what do you need to help you be self-sufficient? And that's what this community advocacy program and network that we have in our other markets will be beneficial in this market as well to help with that.
Nancy?
So very similar with United, we really work with all the providers across the state. So those might be social service workers, they might be employment activity that are already here in the state. And we want to work with them because we know that addressing sometimes social issues or things that are happening within the family or the patient need to be addressed before they can go to their doctor and get their well exam. So it's really important for us to really connect with what are those services in Iowa today and how do we connect those with the patients. There's going to be patients that have very well-established network of caregivers and other patients that they don't even know where to go. And so we're there to really kind of work with both sides of that, making sure we understand from each individual what are the services that are surrounding them today, what's missing, and how can we help provide that to them. And if they have a good network, it's really checking in with them, making sure that everything's still going okay and know that they can come to us if something happens. Maybe a caregiver decides to move out of state, no longer available to them. How can we help educate them and help provide them with services to replace the worker that's left? But every member is at a different place in time. with what services they need. So that's where we try to really understand the individual care needs of everybody. And if that's employment, or if that's medical, or that's behavioral services, whatever that is, really kind of looking at the patient and helping them and their caregivers to find the services that they need for that time in their life.
Mark, you want to share your?
I echo everything that my colleague said, and I appreciate you saying that it's not all about preventive care. That you're right. There are programs and populations out there that have long-term chronic conditions, and it's not necessarily preventive care. It's right care at the right time. And I just want to give you an example. We do a lot of everything that my colleague said, but I was at our state Medicaid department one day, and I got a message from one of the, in this case, it would be an IME staff member, and said they got a call from an elderly lady that had some chronic conditions, and she said her dentures broke. So instead of me passing on that call or telling the state associate that the lady should call us, or instead of giving her a number for her dental provider and getting that and having her do the legwork, I took that information, took it back to the company. The company called her, found out a nurse called her, found out the entire situation, realized that she couldn't chew. She didn't have any dentures. Instead of saying, here's the number to call for our subcontracted dental provider, we called them, had her on the line, did a warm transfer, made sure that the very next day she got some temporary dentures delivered and permanent dentures shortly thereafter. So it's not just preventive. You're absolutely right. It's about real-time solutions for people that have chronic conditions that it's simply not fair for them to say, call your dental provider, right? We have to work with them to make sure that they are getting that appropriate care. In this case, this woman needed to eat. She needed some temporary dentures in order to make sure that she got the nourishment that she needed. So it's not suffering alone. It's reaching out to those people and going above and beyond. Again, this is a theme to make sure that the right care is delivered at the right time.
Let me say to all of you, in your negotiations, when we had our meeting with Director Palmer and a person from IME, it was clear to me that the message that the consumers had the most concern about was what the gentleman said. Hey, my 32-year-old son has had the same case manager for a number of years. Are you telling me that you all might take that away? And so I guess what I would say on behalf of a lot of people, what I've heard is really give serious consideration to using the case management structure in place for various types of these populations. I'm not telling you what to do. No, just a minute. I'm suggesting what you do because my reading is if you as a MCO says, hey, you can keep your present case manager, you're probably going to get these people's business. And if you don't understand, and I'm not sure I understand this, because this isn't my field, but it's my understanding, Mikki, that you contract with each of these persons, and for every enrollee, they're going to get X number of dollars. Is that right?
You mean the MCOs?
Yeah.
They'll get a capitated rate, yes.
Yeah, they'll get a rate, and then they have to provide all the services. And that's why they keep saying, hey, it's to their advantage if they can get you to do preventive care. and it's to your advantage too, okay? You share your name.
My name is Terry Mendel, and I work with the AEA. So I help families that have kids with significant disabilities or any disability and help them find services within our area. I want to thank all of you for being here, and I kind of want to just reiterate what the father in front of me had asked. My hope also is that you will consider the families that have kids with significant needs. My daughter Lisa is 35 years old and has cerebral palsy. She sees a neurosurgeon, a gastroenterologist. She will be seeing a doctor about osteoporosis. She broke both knees just doing a stand pivot transfer this spring. She's the kind of person you don't want to insure, and so I know she'll be a drain on resources. So how do you manage quality care with managed care when it comes to someone like my daughter? Thank you.
Jacqueline, you want to add anything?
Sure. So with UnitedHealthCare, we really want to meet with our patients. We want to see what are the services that they're getting at the home, as well as who their doctors are. And there may be everything that they're getting right now, and there may be some things that are missing. And so that's where we really want to work with all of the members, no matter what their condition is, because it's important to us that every single member on Medicaid get the services that they need. And what we're really hoping to be able to do is to be able to understand what those services are and help coordinate that care if necessary with their case manager or with their doctors, whoever their caregiver team is at this point in time. There's certainly many services depending on the types of members that we have, and we know that some health teams are 20 providers, and some teams, they don't even have a provider. So we will be working with all of them, really understanding each individual member.
Jacqueline, you want to make any comment?
Sure, and I echo that. The other thing I would add to that is, we really encourage active participation with the health plan, be it in our care coordination programs or even our care management programs. We're looking for our membership to be active in helping us develop a care plan, helping us to execute on that care plan to achieve the goals that are necessary. And without that type of active participation, it's usually only one-sided. And while it probably comes as no surprise, there are members who really don't want to engage with the health plan to be an active participant in their own care. So I think that would be my encouragement is that as this rolls out and you choose your individual health plans, that you really decide to become an active participant with the health plan, participate in the interdisciplinary care plan meetings in those situations. Really champion for your loved one and help us provide the right course of treatment and coordinate that with the providers that you have.
Mark, anything to add?
Yeah, just real quick. So, first of all, I want to acknowledge you. Where is she? I want to acknowledge you as an informal caregiver, right? Years ago, health plans, I said I've been doing this for a long time, health plans did not do a good job of recognizing informal caregivers as they care for somebody, in this case, your loved one. And we've learned since then, we're not going to go out and go, you got to do this, you got to do that, you got to do this. First thing we're going to do is say, Mom, what works, right? What has been working? I can tell you an example of a young lady, chronic conditions, very similar. We were, and I'm not a clinician, and the reason I'm not a clinician because the story about your daughter broke my heart. It was just really, yeah. So we were sending 4x4s, which are gauze. The clinical people know this. We were sending this to this grandmother who was taking care of her granddaughter, and we were saying, just cut them, and you'll be fine. Cut them. And the grandmother told us, that doesn't work. I need these, right? And we were going, no, you don't. You use these. We finally realized that informal caregiver was right. And I think you're going to see all the expertise and resources that we have in other states for treating people with conditions like your daughter's to make sure that we're doing right by your daughter and by you as an informal caregiver.
Victor?
So Terry, you have a very complex case for us to manage. All four of us are prepared to help you and support you in managing that. One of the things you can do as an advocate, though, is really make sure that your specialists are being engaged with the IME toolkit, the provider toolkit, and make sure, because the critical piece there is that we have everyone within an understanding of the system, and then we can manage that difficult case. God bless you, and again, we'll be ready to help you manage the care of your daughter.
So what I hear you all saying is that those who have informal caregivers, they can help you by making sure that the person who's providing the care basically contacts you and contracts with you at that point so that they are included in your networks.
Actually, what happens, Bob, is when we come out to talk to that, when we're trying to figure out the needs of that complex care person, again, with the patient-centered care, we're going to see what we can to find out from the patient, but we're going to talk to the family members, to the providers, to the caregivers, formal and informal, because we want to develop a care plan that works for that person.
Thank you.
My name is Karen Friedman. I am not a public speaker. I am the parent and guardian with my husband over there of a 30-year-old special needs child who is right now in a group home with one of the agencies that we have currently in place. I am extremely happy with my case manager. I would really, really have a hard time if this had gotten changed. It has changed periodically over the, I don't know how many million years that we've been, on the ID waiver. The question I have is, and I was told to contact all of you people, is this a done deal? Has this already been decided? Do we have to do this?
Mikki, you want to answer that?
Yes, it is a done deal. We are moving forward with Medicaid modernization and managed care.
And, some of my legislative colleagues would tell you that they have not been in favor of this, but they did find that the governor does have the authority to do this. And Mikki, as the director of our Medicaid enterprise, is doing her best to carry out that directive. Am I saying that right? And what? CMS.
Yeah.
Oh,
Right.
and that's right, the CMS.
And there are questions being raised.
Yeah, so that's not a done deal.
Do you want to comment about anything?
You need to have federal approval to move forward on the Medicaid waiver, and that's what we're working on right now.
They couldn't hear you, Mikki.
We are waiting for CMS approval on the managed care waiver to move ahead, yes. The waiver is not good.
So the waiver's not.
Thanks. Joe Bolcom, member of the Iowa Senate. I live here in Iowa City. Thanks for being here. Great questions. When we arrived back at the State House in January, we were notified by the governor's office that he planned to move ahead with establishing a managed care contract or contracts to essentially turn over the entire Medicaid enterprise, some $4.2 billion, that covers nearly 560,000 Iowans to private companies. And he has the authority to do that. There are a number of us in the legislature that are opposed to his decision. And but we don't have he didn't really consult with us, and so the Lieutenant Governor, Kim Reynolds, and the Governor are moving ahead with this process. They've gone through the process of awarding the contract. You're meeting some really good people here today that received the contracts. And last week we had a call with CMS, a number of my colleagues, trying to make sure that as this goes forward, they make sure that consumers in Iowa, providers in Iowa, are protected by whatever the waiver, the so-called waiver, what that ultimately looks like. They indicated to us that they are kind of bound to work with the executive branch, and we shared a number of concerns, some of the concerns we've heard here today, but I think that it's pretty likely that the waiver is going to be approved by the federal government, unless there's something dramatically wrong with the application, and I don't expect that they're going to find anything that's dramatically wrong. We encourage them to slow this down, slow the process down, but the governor and Lieutenant Governor Kim Reynolds have had the ability to do this without legislative consent. So is this a done deal? I'm afraid it is.
Senator Bolcom, is there a public comment period for CMS?
On that waiver, we just finalized the public comment on that. But
No, I mean CMS has a comment period. The feds have a comment period, don't they?
Well, I think there's been an open comment period. Those comments have been submitted to the Department of Human Services, and the department is moving to consolidate those concerns, to share the concerns they've heard from the hundreds of Iowans. Many.
I thought CMS also at the federal level has an open comment period after DHS does their open comment and submits it.
I think anybody is free to submit their concerns to CMS right now. We anticipate, I think, how soon do you anticipate the waiver being approved by CMS? Do you have a sense?
we don't have a significant timeline, but I do want to remind people here, managed care is not new to Iowa. How many of you have Magellan or Meridian Services? Those are managed care companies that are managing care on behalf of the state. And they are a small segment of this. This is a total comprehensive managed care movement. It's not new to the states in the United States. There's about 39 states right now that have moved their entire Medicaid operations to a managed care model.
My name is Debbie Musser, and I have 2 children with special needs. And all of you have talked about the boots on the ground that you're going to be using to address our needs. And my boots have always been Johnson County Social Services, and I don't want that to change, ever. You also have talked about the preventative care. My children actually happen to be in very good health. Their needs are totally different than the health issue needs. And it's so vague. Everything you've told me is so vague of what they need. And also the preventative aspect of it. My special population seems to get, we don't go to the Boys and Girls Clubs, so we can't get these incentives that you've all been talking about. My hope is that you will include them in a lot of these programs that you were talking about, preventative, because they tend to be neglected and left out of those.
Hi, my name is April Stump. I live in a rural area south of Iowa City, and I'd like to thank you all for coming and listening to the comments and questions today. My husband and I are parents of 3 children. We both work full-time, and one of our children is 3-year-old, and she is severely disabled. Requires 24-hour nursing care. We are informal caretakers. She cannot speak for herself. So I speak for her. I know many of the legislators I've met at the Capitol. I'm there speaking for her quite frequently. And I guess my hope is for you to recognize that some of these preventative measures we take with her. Okay, we are not these parents just sitting back saying, oh, we have this child with special needs that may not live to be 10 years old. We fight for her every day because she fights every day. And so, you know, some of the incentives and things like that, she is blind, she is deaf, she is fed through a feeding tube, she is 9 specialists, she has 14 medications that I would love to not have to give her. But at this point, we are at no choice. Being in rural Riverside or south of Iowa City here, we have a heck of a time finding in-home nursing care and reliable in-home nursing care. And being a parent with 2 other children and working full-time, it makes it extremely difficult to get that call at 4 in the morning saying, hey, April, I'm sorry, but we don't have a nurse to come and be with Quinn today. And it takes a lot as a parent to hand over your child to someone else's care, but then to be so uncertain that they're even going to show. So I ask you, it is so hard now to jump through so many loopholes for care and finding reliable nursing care. I really hope that that's something that you can focus on. I am more than happy to take your business cards and work with you one-on-one. I can answer any questions you would like. I'm happy to do it. So anything that we can do, I know any caregiver here would be happy to do so. And thank you.
I think that y'all getting the message, okay?
Hi, my name is Kim Majerus, and I actually come at this from 2 different directions, and I have comments and questions. I am the mother of a 26-year-old son with special needs. He functions mentally at about a 5-year-old level. I want you, and it's been brought up very much so by other people, to remember how complex care is. And it's not just the medical care, and I agree 100%. I mean, he attends 2 different day hab programs so that we can get the vocational, which is also part of the needs, that we can get the recreational and the socialization. He is part of Consumer Choice Options. And if you're not familiar with that, please familiarize yourself, because it's been the best thing that ever happened in his life as far as being able to be out and in his own apartment. I manage that. And that's one of the things with Consumer Choice Options. You need to have someone who's willing to kind of be in charge and train the staff and all of those things. But be familiar, because it's growing, I know, in this state, and I hope that that continues to be part of what is received. My son goes to the University of Iowa for all of his care. But my usual joke, and I understand this woman saying you see, many doctors. My usual joke is that my son at 26 has seen every department but the OBGYN. So, couple other things I want to say is that you've heard, don't reinvent the person's system if it's working. I mean, I've been doing this, as other parents have, for all of the years of that child's life, and it hasn't come easy, and it's come with lots of, again, one of the things I say, his life has been a constant experiment. And so if that experiment has led us to a pretty good place, please be sure that you respect that. When you are looking at preventative measures, preventative programs, things, and this is the other aspect I come at this from. I'm a physical therapist, and I have been doing healthcare for over 32 years. And prevention is not just about those programs, at a wellness center. That'd be great, but my son couldn't go there by himself. Prevention can also be something like not discontinuing the services of the physical therapy, the occupational therapy, and the speech therapy. And it may seem like it's expensive, but if my son needs a brace to keep his hands so that they're mobile, and you pay that one price of that brace and for that occupational therapist versus paying for him to have orthopedic surgery 5 years down the road, you've saved a lot of money by doing the rehabilitative care up front. So another thing that I want you to remember, one of the other things that I have to ask as a provider and then also as a parent is, will providers be monitored to determine their outcomes, because I believe that's important. And that will ensure that our children, family members, whatever, are going to be getting the best care that they can get. So that's one of my other questions. The other thing, and I reiterate what the mother right before me said, is that any of us in here, would like to help you as you move forward. And I personally want to say, I'm open for a new job. So if somebody would like to employ me, come find me. Whoops, sorry.
Mikki, am I not right? Consumer choice continues.
That's correct.
Yeah. So the consumer choice program continues. Okay. I forgot to make a note. You had another question.
It's oversight.
Oh, the oversight.
About,
yeah, oversight.
Accountable, the providers, and looking at their
Yeah. You want to comment?
At the IME, we'll have a major oversight initiative, and that's part of what the readiness review will point out, holding the providers and the MCOs accountable to deliver the care. There will also be quality matrices that we will be utilizing as well.
And I have one more question. When we call each of you, will we get a person, or is it going to be, please push forward, please push
If they're going to get a person, will you raise your hand? You're going to get a person, okay?
Good afternoon, almost good evening. My name is Chuck Friedman.
Not long enough.
My name is Chuck Friedman, and my daughter is a special needs child. I have there's a few takeaways, and I do have a question for Mikki. One is we learned that this is a done deal. Two, that there is time frames, October 15th to December 15th, to make a decision. That's not a whole lot of time for me as a parent and a guardian to make a decision. Philosophically, I heard from all four of these MCOs, and I'm going to be honest, I don't know the difference. I think I'm concerned about the time frame. We're going to get packets from the state or from somewhere. And this is a question to Mikki. I just went through Medicare enrollment. I've gone through enrollments with various employers and trying to read and understand differences between the PPOs, the HMOs, and the different plans being offered. As a citizen of Iowa, I expect the state to provide me with readable, understandable information so that I can distinguish between these four plans, whether it's not just the list of providers. It's the state is paying per capita. So what's the difference going to be me, to be me for my daughter, to make an educated selection? And the state needs to help me. I don't want to receive information from Medicare from 12 different companies that I couldn't understand, that I couldn't read, that was difficult to make a decision. And I use the SHIP network from long-term care, and that they navigated me through the system. And in 2 weeks, we're going to be getting packets to make a decision. So I'm asking Mikki and the state, I need your help. We all need your help to make educated decisions for our children and all of our consumers. And without that, this program, to me, will not work.
Thank you.
So one of the things that we talked about earlier today was our member services. Our member services is turning into an enrollment broker. It's going to be more than just calling member services with a question. The member services will be trained and educated on the various plans so that, similar to SHIP, they'll be able to help navigate members through the process.
Hi, like some of the other people with a comment, I'm also the parent of a special needs child. She's 8 and she's on the autism spectrum and is intellectually disabled. Currently, we have since she's so young, she's still covered under my husband's employment insurance as well, so we receive our preventative care through them. And so we would not be, until she's 26, needing preventative care. But the things we do need are things like help teaching her how to communicate, help teaching her how to be the best kid to reach her full potential. And I'm wondering if you guys are going to be able to cover those therapies and services that she needs to kind of just to reach her potential and be a more productive member of society. And the other question I had, one thing we've dealt with our primary insurance is calling them, they've told us repeatedly that services are not covered that are. And I'm wondering if this happens with the under the managed care, is there a person I can talk to figure it out and really find out what's really covered?
Again, it's with the broker and the enrollment services and provider services. We should be able to navigate you through what's covered and not covered.
Hi, my name is Stephanie Baumgartner. I have 2 kids on the autism spectrum disorder, and I am just really concerned because I live in Royal, Iowa County, Williamsburg-wise, and we have a really broken system in that area. My case manager has recently retired, so I have no case manager right now. I'm trying to figure out who's going to be my case manager in the future. We had Systems for a while, and Systems has quit all of Iowa County. So no one in Iowa County has Systems anymore. So, or at least in Williamsburg, Iowa County has Systems anymore. And also, I have Consumer Choice Option, which it's great for Consumer Choice Option. I have 1 caregiver for my 2 children for Consumer Choice Option. I am looking for more, but I'm having a hard time finding more caregivers for my kids. I also, my daughter, her name's Samantha, she is more disabled on the autism spectrum than my son is. She is really struggling in her speech, and she needs more help with her speech, and the school is even telling me that possibly she might lose her speech services through the school within the next year because she's not making enough progress with that. So I really need help with making sure she's going to get that help with her speech, because I still believe in her that she's going to outgrow this disability and she's going to be able to become whoever she wants to become. And she's not going to have to live at my house for the rest of her life. I still believe in her. So I just need some more help with all these services that are broken already. And now I feel like they're going to be broken even more because I don't know what's going on with this new care that we're going to be getting.
I'm Robert Leon, and my hopes are like really slim with the providers. And why? Because they can't provide they cannot provide what they say or when they say it. I have to rely on myself and basically stand up for other people. And I think there should be a program or something out there like a crisis center and a provider. Like I like all my case manager, everything. I like the way it is. It's the government changes everything, and I think the government needs to take ownership for their actions. I'm upset. I'm here because speak on behalf of these people, and I want action. I'm unhappy with it.
I have to bring it a little closer. Do you want me to get closer to you? Good? Okay. Hold on just a second.
He wants to get closer to me.
Yeah, I do. Hi, my name is TJ Cassidy. I am a local here in Iowa City. I have a couple of concerns, two of which that have been kind of echoed throughout the past few speakers here. I am 40 years old. I suffered a spinal cord injury 21 years ago, and I'm living independently. I've been through school. I, like most of you, have a mortgage that I pay, and I am able to do that through a Medicaid program, which is called the Medicaid for Employed Persons with Disabilities, the MEPID program. And it's a beautiful thing that I want to see continue because it's basically allowed me to be a member of the community. I pay others to help me into bed, to give them an educational chance to work with a person with a disability. And not only that, I work out of the home. I pay taxes. I pay property taxes. I vote. I do all of these things, and I'm able to do that because I have that program. And I am very scared that I will lose something like that. And what that will do, and for people like myself who may not be on this program specifically, but like it, will be put on the verge of not being able to stay in their own homes. I have heard, a lot of you, which I want to thank you for coming out today, actually. Thank you very much for your time and for allowing us to have a back and forth like this. The one thing I've heard a lot about that I've heard from you is that that concern of getting people in managed care facilities and assistive care. I don't want to go into one of those. I want to stay as clear far away from that as possible. So that is one of the fears that I have, is that with this new shift in how our care is going to be managed, I really want you to be thinking about people like me that have struggled. I went to school. I've fought every day to be here. So it would be really, really hard for me to lose that. And I just would like to make sure that all of you keep that in mind, that there are people out there like myself that are disabled that, go through that everyday fight just to be in the same situation that you are. And I just want you to not make that harder. I just want you to try to make that as easy as possible. So thank you.
Mikki, will that program continue under the managed care?
My understanding is, it is, but we'll verify it for.
Let me tell you, we're running out of time, so don't have anybody else come up in line, okay?
Hi, I'm Mary Schmidt. We are parents of a spinal gifted child that when she was born, they said, put her in a home, don't get attached because she won't live to be 2 years old. Today, she's 52 years old. We had to go to California for a funeral last month, and every health care provider that would come to the home told her she could not leave the house. Carl is very independent. She loves her sports and book clubs, church. She didn't want to be cooped up in the house for while we were gone, and so she called and finally got one person that said that she didn't have to stay in the house if she paid it out of her own pocket. She paid about $1,000 for Dad and Mom to be gone for 5 days. So we are quite concerned about the care, and we wonder what the relationship is with Blue Cross and Blue Shield with your foursome.
There isn't a relationship.
No relationship.
No, okay.
Hi, my name is Alicia Henley. I have 2 disabled people in my home. One is my brother-in-law, he's mentally disabled, and one is my wife, she's physically disabled, both on Medicare, and we survive on CCO. That I've heard it echo through, and we don't know what we would do without it. I am the caretaker for both of them, and it's a very important role in our home. And we don't want to see it go away. And as far as the case manager, we've had the best case manager that we've had. We've had several, but we would like to keep the case manager that we have, and just like you to know that CCO is a very important thing. So thank you.
Hi, my name is Linda Lown, and I'm a legal guardian with someone with a disability. My question to you is, 2 of them. One, you mentioned that the provider could be added on if they choose to, if they weren't already added, which is nice. And then the main physician, do they have to refer the person with a disability to a specialist? Or can they go if they've already seen them and the specialist is already on the MCO?
Similar to what we do today, we would have to adhere to the state plan amendments.
Can you speak up a little bit?
Sorry. It's okay. Definitely. Similar to today, they would follow the state plan amendments for the programs and stuff that we've outlined.
My second question is, it has dental services provided by Iowa Medicaid or Delta Dental will stay the same, will not be provided by the MCO. So they'll keep the same card that they have originally. And then when they sign up between October to December 15th, besides receiving the packet, the information, then shortly after that, before January 1st, they'll receive their cards, which will also cover the pharmacy, I'm assuming.
Okay, so just to help a little bit, dental is a carve-out. So dental will stay independent of the managed care initiative. And then, so you would have Delta Dental as your insurance for your dental care. Is that what you're asking?
They wouldn't have Medicaid like they have now?
It is Medicaid, but the dental is...
Delta Dental will be the new card that they'll receive for January 1st. And then they'll receive the other card shortly after, so the health care would cover their pharmacy.
Yes.
Okay, that was all.
I'll make this really quick. My name is Mikki Dunn, and essentially, I'm concerned, and I know that Mr. Bolcom addressed this, the business of how fast this is going, because as I heard some of you say, you are really interested. I mean, I really trust that you care about people. Everybody on this panel does. However, as you described the process of making sure that you know the ins and outs of every client's needs, what they have in terms of needs, what they have in terms of current care, who their current care providers are you going to each send an army to Iowa to talk to us?
Boots on the ground.
And what time shall I cook the chicken? It's, honest to goodness, I'm trying to visualize this, and I don't know the number, but it's over 50. And they're going to talk to everybody that's in the family that's already providing care. You've got a monumental task ahead of you, and we're talking, and I don't do math, I teach reading, and there's a reason for that. How many months is it from now until January? Not very many. And I know how long it takes me to get my husband to do the taxes. And he's just one stack of papers. He doesn't even have to leave the house to get them. So I just really, my hope is that you're able to deliver on this. And my hope is that Governor Branstad hasn't cut off more than we can chew.
At the end of the earlier session, Senator Bokum expressed the hope to all these persons that they would come back in, I think you said a year, and meet with us and be able to report the success. Let me point out to you what I heard, okay? You do have some responsibilities at this point. If I was you, I would make sure that the people who are providing me services contact these 4 managed care organizations and ask to be a provider, okay? And if they say no, let Mikki know, okay? If you've signed the register came in, and if you printed so I can read your writing, I'm going to create an email address, and I'll just send it blank, but all your names won't be on it. But I'm going to send it once. I'm not going to personalize it for each of you, but to get you the information. You know, some of them have said they're going to send me information, and I will send that on to you, okay? And we'll try and set up a network at this point. But you've got a responsibility, and that is talk with your providers, see who they have contracted with, you know, encourage them to contract, make sure you have, and make sure that the providers that you want are in one of these or all 4 of them, okay? If they're only in one of them, then that makes your choice easy. If they're in all 4 of them, that makes you more difficult. And to you all, I guess what I have to say is, you know, certainly know I'm a retired minister. Please listen to these persons. They have concerns. They are counting on you, you know. You've signed up for one, if I can use the term right, hell of a big job. And you know, the 265 people who were here first, and probably an additional 90 or 100 now, are really counting on you all. Mikki, you also have one hell of a big job. And please in your negotiations, you know, you always wonder about, is the timing of this forum good? I guess my feeling is, I'll answer that yes. I think it is good because you haven't all negotiated the contracts. And so, Mikki, I guess one of my hopes is that in terms of working with these 4 companies that you all selected, that you will make sure that whatever you negotiate takes into account what these people have said. Okay? You want to say anything?
Again, I want to thank you for the feedback. I also want to point out a couple things. One of the things is that there will be some additional meetings, so we can get some additional feedback and we can learn from you, your concerns, and I definitely appreciate the time that you guys took out of your schedules. I know a lot of us took away from your families and your work, and we do appreciate the feedback, and we'll continue to move forward, and with your support, we'll continue to try and get the answers to your questions met and try to serve you and everyone else in Medicaid. Thank you.
Thank you. You probably noticed the lights, and Coralville Television has taped these 2 sessions, okay? When they are available on cable and on Channel 5 and also Iowa City Channel 4, we will notify you that they are up and running. And so would you join me in thanking cable television for doing this? And before I ask you to thank these people, I've got another gist. A few of you could do this. Most of you could not. But Larry and I and Sean and Jane have the responsibility of putting this room back like it was before we can leave. And we would appreciate if you'd sort of stack up the chairs in 5 and all, and listen to whatever Larry says for you to do, then do it. But before that, I didn't know you all at 10 minutes to 1 today. I do feel like I know you. I'm trusting you all, okay? And please, dadgummit, don't let these people down. Don't let the aim of this whole program is to improve the coordination and quality of care while providing predictable and sustainability for our taxpayers in Medicaid spending. And with your help, we can make that happen. And so would you join me in thanking these people? And drive carefully.